Right, welcome everyone. So order of the day is lung ultrasound. We're really going to be talking about a bit of the quirky physics because I like it, and we'll touch on COVID ultrasound again because it seems to be a little bit more frequent in the last couple of weeks, and a few people have asked to go through it again. So I'm Anna Colclough. I'm a consultant in emergency medicine at Lewisham, and I do various PocUS things for BMIS and Essang, and ultrasound lead at Lewisham. So ultrasound in the lung, I imagine some of you have done some already, so this will be a little bit like teaching you to suck eggs, but air is the enemy of ultrasound. I'm sure you've noticed that if you stick your probe on the abdomen for an aorta scan, if they've got lots of bowel gas there, it's all very, very difficult. So why does that happen? It's all to do about acoustic impedance, so how easily the ultrasound travels through tissues. If there's a big difference in that particular property between one tissue and the interface of another tissue, everything's going to reflect. So we've got our figures for acoustic impedance here on the left side. So for air, it's very, very small, 0.0004, and for soft tissue, it's an average about 1.6. So that change is what's important, and that means that pretty much nothing gets through that boundary and everything bounces back either to the transducer or, depending on the angle, off somewhere else. And bone, you'll notice, is quite different to soft tissue as well. So bone has an acoustic impedance of 12, so huge difference there as well. It also absorbs quite a lot of the ultrasound. So in our thorax, with all our air and bone, it's a real nightmare for the ultrasound to get through to look at any of the tissue beyond that pleural line. So what we rely on really with lung ultrasound is artifacts, and there are various different patterns of artifacts that we look at and try and interpret. So just going to go through the setup a little bit. So we can use either the curvilinear probe, or if you've got one of our new fancy handheld devices, the combined probes with the appropriate presets. Curvilinear probe might be more appropriate if you're looking for deeper artifacts, your B lines or consolidation. Linear probe is better at looking at the pleural line in a bit more detail. As you know, it doesn't penetrate quite as deeply. The preset is the software that your ultrasound machine has to try and give you an image that's most suited to the area that you're looking at. So for example, an abdominal preset gives you quite a smooth sort of render, smooths over your artifacts and gives you nice clear boundaries of organs, whereas a lung preset will look a bit more grainy and all those artifacts will be nice and bright. But if you're using a curvilinear probe, you may find that you don't have a lung preset on that probe and you'll have to use abdominal. And because the abdominal preset often have these tissue harmonics and compound imaging on them to try and help you out, that can hide some of the artifacts you're looking for. So if you have the ability to turn off the tissue harmonic imaging or the compound imaging on your machine, you'll have to have a little look through the manual or look at your machine to work out how to do that. That can give you a much better, clearer view of your artifacts and stop over or underestimating them. For B lines, we're looking at a deeper depth, so getting down to 12 to 16 centimeters, and most of our views will be in a longitudinal plane, so looking with the pointer upwards between, with a rib space in between. And one of the biggest tricks with lung ultrasound is that we keep that beam perpendicular to our pleural line. So that may not be perpendicular to the skin as we go around our thorax. We've got various lumpy bits of fat and breast tissue and muscle, and we need to just constantly be adjusting the angle of the beam so that's nice and sharp against the pleural line. And then you'll find your artifacts, like your A lines, are nice and clear as well. So what protocol do we use? What areas, what zones do we go in? There's lots of different protocols out there. This is just an example of some areas that you could scan. So this is a 12-zone protocol. So you do 2 anterior zones, 2 lateral zones, 2 posterior zones. That's quite common. And on the top left, you'll see the two orientations standard for the probe. So the longitudinal, where we have a pointer upwards, and it's going across two ribs, or we can have a look between within an intercostal space to get a slightly longer strip of pleural line, if that's what you need. On the right here, we've got a protocol suggested by Gio Volpicelli. So he's an Italian physician who does a lot of lung ultrasound. He's one of our pioneers, and he does this 14-zone scan. So the only difference here is the way he's labelled it. So he numbers it slightly differently, and he adds this third zone on the posterior, which I think is quite useful, because actually the posterior area of the lung is quite a large area, and as you can see, that fifth basal area covers quite a long stretch. So it does just point out that zone in a bit more detail.
From Pleura, lotus root with origins in Japan.
Someone just needs to mute themselves. Okay, so I'm just going to show you this video. It is muted. I'll talk you through it because there's quite a lot of background noise on it, on how I do a 12-zone scan. So this is a normal subject in ED, and I'm using a point of care ultrasound machine called a Sonocyte Export, and we've got Mark here who allow me to draw on him with marker pen. And I'm going to use this curvilinear probe. This is our lower frequency probe. And I've got it at the moment on the abdominal preset. I've got it down to a depth of about 13, 14 centimeters there. And the first thing I'm going to do is try and get rid of those tissue harmonic imaging and the compound imaging. So I've just gone to more controls, and then you probably won't see it, but there's a THI and Sono MB on this machine. I'm just going to switch those off. And now I'm going to start my scan. So if we try and remember a system so that when you acquire your images, you can remember which ones, what order you've done them in, so that you don't have to go around labeling each one. Obviously, it's ideal to label, but that can be quite tedious for lung. And we're going to stick it straight across a rib space. So at the top of the image, at the top of the image, we've got our pleural line here. The image at the bottom right is actually a butterfly image, just because it was easier to transfer to this movie. So it's very close to the top of that box. And then we've got a rib space, a rib shadow on either side. And we do a little slide just along that top zone. And then we're moving down into the second anterior zone, making sure we've got a perpendicular angle to that pleural line, and another little slide. And we're going to get the patient to put their arm above their heads. Next zone, so we're going to go up in the axilla. So axilla is still lung, sort of close to the apex of the lung as we can. And here, because you've got axilla curving, you've got your thorax curving, it's really important to keep adjusting that beam. Our ribs are also running a bit more obliquely there, so you may need to change your angle a bit to get that nice strip of lung, of pleural line. And oh, sorry, get rid of that. There we go. And down at the base here, we're looking at that costophrenic angle. So here at the right upper quadrant, we've got a bit of diaphragm, liver, you can see kidney there, you might recognise that from your fast scan view. And as Mark takes a breath in, we get this curtain of pleura or artifacts coming over the abdominal organs. So that's already quite reassuring that that lung is air filled, because it's got all that artifact there. And at the bottom of that image, when it's in the abdomen, you'll see this this undulating bright line. So this is our thoracic spine. So when the ultrasound goes through the abdomen, we can see that because it's got a medium that it can travel through. But when it hits the lung, we lose that spine because it's just reflecting all the signal. So if you're using a different machine or a butterfly, you often have to change your preset back to an abdominal one when you're looking down there, because it can look quite dark if you're using a lung processing, if you want to see that bright diaphragm. So here I'm just doing a slightly different technique, sort of lawn mowing up and down. You can do it along the rib spaces as well, which I'll show you. And then to look at the posterior views, so sitting him forward, getting him to cross his arms over his chest so that it allows you a little bit more space. So it pulls the scapula apart. And we've got 2 zones here on the back, but you can see they're quite big, so they could be easily split into 3. Pick a zone, do a little slide. So closer to the top, you will have just quite a small space to slide between your spine and the scapula. And then as you come further down, you'll have a little bit of a larger zone to slide across. And most of the pathology is found in the posterior lateral zones, in particularly in pneumonias and COVID-19. So here I've just orientated my probe into a transverse orientation, and that allowed us to see a slightly longer stretch of pleural line there. So if you've got a bit that's stuck under a rib shadow, or you just want to see the extent of an interruption or a bit of consolidation, that can be quite useful. Okay. So here I'm just working out which bit's abdomen, which bit's lung. So I'm just sliding up until I was definitely in the lung, and then I go a rib space just above and interrogate that whole intercostal space there. Okay. And then I was just going back to the costophrenic angle there in the lateral zone. I was just showing you this curtain sign. So as he takes a breath in, that lung artifact comes right down over the abdominal organs there. Okay. So this is just to show how the lines of the ribs and the intercostal spaces vary as you go around the body. So it's quite curved at the front and then much steeper on the sides. And the bottom of the diaphragm at the back is very, very low down. So it's just aware that as you go around, you need to follow the curvature of the body and of the intercostal spaces. And this is this lawn mowing technique. So this is quite a detailed way of scanning. So just scanning across one rib space all the way along, and then as if you're mowing a lawn, down onto the next one, all the way along. You're constantly having to adjust. It's quite time consuming, but if you're looking for, you know, tiny little focal areas of abnormality, if you're really convinced someone has a viral pneumonitis and you're trying to find your evidence, you can do it this way. But I think most it's small wins for quite a big amount of effort, and the other protocols are just as good, really. Okay, so once you've got your images and you want to interpret it, you might use this sort of decision protocol here. So this is just someone's suggestion on Twitter. So this is very similar to the blue protocol. So it's looking at different profiles. So has this patient got A lines or B lines, and is there lung sliding, and which pathologies are most likely. So that's just an example, but really when we talk about lung protocols, we often talk about the blue protocol. So this is one that was cooked up by Dr. Lichtenstein, who was a physician in France, and he came up with a really a 3-point scan, or 2-point and then plus, to look for major abnormalities in the lung, and it might be augmented by a DVT scan. Sorry, my dog is just eating something down here. Let's go eat my rock. So the 3 points are 2 anterior or slightly anterior lateral on the front. So we've got our hand just below the clavicle, going at the level of the second finger for the first point, and then hand below going in the mid palm for the second point. And then if we do move on to the plaps point, the third point, we slide our hand straight across and to the posterior axillary line, and that gives you your plaps point. And the protocol we follow is this. So firstly, we're looking for lung sliding. This is just in the anterior zones. Is it there or is it not there? And then we're deciding whether there is an A profile, so that's A lines, or a B profile, it's B lines. And then we can follow this flow chart. If we're still not getting any particular pattern or pathology, we can then go on to look at the deep veins and see if there's any evidence of a DVT. And if it still doesn't suggest any evidence of a DVT, then we can move on to the plaps point and look for pneumonias. And if there's nothing anywhere, then we're considering an inflated lung like a COPD or asthma. So this was from a study where they enrolled consecutive patients in ITU, and the physicians who scanned had no knowledge of the history or the examination or the lab results or the chest x-ray, and they had to come up with the most likely etiology of their respiratory distress, their respiratory failure, and they had pretty good results. So it was about 260 patients, and there's some caveats. They excluded what they considered were poorly defined diagnosis or rare diagnosis, which actually also included large pleural effusions. But given that they had about 90.5% correct diagnosis, so and that most of the time they're using CT as a gold standard there. So pretty good results, and that's why it's been adopted by critical care and famous as a good protocol to use, and it's quite nice and easy to do as it's mostly anterior. So this is just an abridged version that famous has suggested if you don't like flowcharts. Okay, so we're going to move on to those artifacts. So here we've got what we recognise as what we used to call our bat sign, so rib shadow with a bit of pleural line in between. And that pleural line is this very reflective, shimmery line here, and you can see it's just at the base of where the ribs curve. Above it, we've got a bit of intercostal muscle, and above that it's a little bit reflective. So some people have quite bright tops of intercostal muscle, so just make sure you're definitely looking at the pleural line and not that. And below the pleural line, we just have rubbish, really. It just looks grainy, artifacts. It looks machine generated. So we've got some of these little laser beams shooting down, these comet tail artifacts, which attenuate as they go down, so they don't quite reach the bottom of the screen. And we have some horizontal lines, which are known as A lines, which are a type of artifact brought about by this very reflective pleural line. So comet tail artifacts, here we've got in just closer detail. So they originate at the pleural line, and when we see them, it suggests lung sliding. And on just a B mode image, you can also see these little dots shooting along or shimmering on that bright pleural line, and you can see that they're in motion. So some people consider that to look like marching ants going along this pleural line. Another name for the comet tail artifacts is a short path reverberation artifact, of which B lines are also a subset. So we'll talk about that a little bit later. So if we've got not the clearest B mode image, or if lung sliding is a bit subtle, we can use M mode. And the M mode allows us to sort of pick up sliding that might not be so clear just on the 2D B mode. So M mode is motion mode, as I'm sure you'll know, and we put this line right down the middle or of the pleural line, or the area of the pleural line that you're interested in. And in a normal M mode image with lung sliding, we will see this sort of appearance with horizontal lines going across the top, and that's all the tissues above the pleural line that just staying still. And we've got a much more chaotic speckly picture below the pleural line. So what it's supposed to look like is waves crashing on a sandy beach if we've got lung sliding. So if we lose that lung sliding, we lose the chaotic pebbly beach at the bottom, and we'll just have these straight horizontal lines going all the way to the bottom, and that's known as the stratosphere sign. Now, sometimes that difference is very subtle. If someone's got very sticky lungs, ARDS, or is having very small tidal volumes from ventilation, that can be quite difficult to pick up. So we can rely on something called a lung pulse or T lines. So here we've got still an M mode image. It's a little bit speckly down here compared to the top, but if you can see, I've marked them in pink, these lines. So every time there is a heartbeat, there's just a little bit of a slide that's being picked up by the M mode. And so that shows that there is lung sliding. There is an interface between those two, that parietal and that pleural layer. Okay, so what's a reverberation artifact? So A lines are this long path reverberation artifact as opposed to the short path reverberation artifact or the comet tail artifact. what that means is you've got a very bright, brightly reflective interface. And as the ultrasound pulse comes from the transducer, it bounces straight off that and it goes back to the transducer. Now, some of it gets picked up and converted to the picture on the screen. Some of it reflects off the surface of the transducer and goes back again and doesn't get recorded until it comes back a second time. So this ping-ponging back and forth leads to the machine interpreting that image as being a bit further away than where it actually came from. So as a consequence, it marks that line further down the image screen. So we get these superimposed horizontal lines that look like pleural line, but they're fading and equidistant as they go down. So that might be bouncing back and forth between the transducer and the pleural line, or it might be bouncing back and forth between the pleural line and one of the muscle fascias, whatever reflective structure it might be. But all that means is that you've got an aerated area of interface. So it could be air outside the pleural line, it could be a pneumothorax, so there's still air tissue interface, so you'd look for lung sliding, or it could just be normal aerated lung, or it could be non-normal lung such as COPD or asthmatic lung, but still air rather than fluid or consolidation. Another example of a reverberation artifact not in the lung is just here on the right. So this is a needle. This is going into just some tissue. I think this is an ankle. And we can see when the beam is right bang on perpendicular to this, this needle, we've got these horizontal lines coming off it, and that's reverberation artifact as well. Okay, and this just shows how the signal is being attenuated as it reverberates as well. So it'll ping pong back and forth and then gets wasted as it goes down. I'm not sure it's going to play. Never mind. Okay, so B lines. So these are certainly the prettiest artifact. We can see they originate right at that pleural line and they traverse the whole screen. They go all the way down to the bottom of the screen, and by definition it should be at about 16 centimeters, although you can work out if it is a B line with less depth than that. And you can look for different patterns. Are they bilateral? Are they equal? Are they becoming confluent? Is there a gravitational element to them, distribution to them, or are they in focal patches? And it gives you some clues to pathology. But what are they? So again, we've got our probe onto the tissue and the ultrasound pulse is coming through the tissue. But this time we've got a small sphere of fluid just below the pleural line. And that's surrounded by air in the lung. So traditionally you would think about an alveolus that is full of fluid, and it allows the ultrasound to travel through the pleural line rather than reflecting straight back up into that little ball of fluid. And the fluid then bounces back and forth within this little sphere before coming back to the transducer. So what the transducer reads is that it's taken, again, a longer time to come back, and it will mark lots of these little anterior and posterior walls of the spheres down the page. Now, because it's fluid, the signal doesn't attenuate. So it continues to be quite bright as it goes down, as opposed to the long path reverberation artifacts with the A lines where it fades. So here, the little lines are going down the screen, but they continue to be quite bright all the way to the bottom, and they should traverse the whole screen. Now, in reality, the little spheres, the alveoli, are so small that these reverberation artifacts become confluent, and you just have this one continuous light beam sign. And if you've got it on a curvilinear probe, that will look like it's widened just because of the curved sector shape of the curvilinear probe. So you get this light beam effect. So the short path reverberation artifact is when there's a very two reflective structures that are very, very close to each other. In fact, so close that it has to be less than half the length of the echo pulse. So an alveolus is sort of 0.2 millimeters, and so that gives you this traditional B line. So a comet tail artifact is this ring down artifact also, but this time it attenuates. So a comet tail artifact happens when it hits something fibrous rather than fluid filled. So it will still have a bit of reverberation, but the signal will be lost as it goes down because it's not fluid filled. Or it can be an irregular shaped structure that it's reverberating off, and some of the signal will be scattered, but either way it attenuates, and that's a much more innocent artifact than a beeline. And finally, the other, well, actually, you've got two other things: consolidation on ultrasound, and we see as hepatization of the lung, so a more tissue-like appearance of the lung. So rather than having that grainy speckly appearance or the mirroring that you often get of the liver above the lung, you get this much more solid looking chunk of liver at the of lung at the base that looks a bit more like liver and has these bright spots in it, which is air bronchograms. So again, the air trapped in the consolidated tissue will reflect quite brightly, and sometimes you can even see the bronchograms moving, as called dynamic air bronchograms. As that consolidated lung hits a bit of aerated lung at the border of the consolidation, you get something called shred sign, and that looks just like a shredded bit of paper. So as it gets aerated, you get some beelines coming off it, and it's a sort of irregular shredded looking pleura. So that's here. So it has this irregular looking rough pleura at the base of the lung where the consolidation starts. There's a bit of an effusion there too. You can see our spine visible there at the bottom. So the spine side, so again, I mentioned this earlier, here we've got the ultrasound beam going through our liver. This is the diaphragm. So above the diaphragm, we just have lung, it's all aerated. And as a consequence, this thoracic spine, which is the line at the bottom, does not continue up into that lung cavity. But if we've got a bit of fluid there, suddenly we can see the thoracic spine going up above the diaphragm. So we know that there's a little bit of something that's able to transmit that ultrasound signal to the back. So here we have it. Ooh. Emotion, never mind. Doesn't want to play. There we go. So we can see that tip of the lung in the sac of fluid there. Okay, so lung ultrasound in COVID, just to remind ourselves, so we've got our different probes that we can look at the lung. So on the left, we've got our linear probe, so nice thin pleural line there, some A lines, some comet tail artifacts. In the middle, we've got a curvilinear probe. It's actually a butterfly probe. And we've got a bit more of a curved looking A lines, bright pleural line that's a bit deeper. And then on the right, we have got one or two B lines in a normal individual here. Anything above 2 is considered abnormal. And if we're covering more than sort of 2-3 zones, then we're thinking about pulmonary edema normally. So this is a chest x-ray of someone who's come in with our fever, loss of sense of taste and smell, a query COVID patient. And they're very breathless, but our chest x-ray isn't particularly convincing. So with the eye of faith, maybe that right side looks a bit more dense, but certainly nothing barn door. So back in the day, we didn't have lateral flows or anything. We needed other modalities to help us. So early in COVID, we might see some changes like this. So we've got this roughening of the pleura, some areas where the pleura doesn't seem complete, so little interruptions of the pleura, and we're starting to get some of these B lines. So with the linear probe, with the B lines look much more pin-like than they do with the curvilinear probe. There's already some abnormalities there. It doesn't seem to be sliding like normal. These findings are not specific for COVID. These are findings of any viral pneumonia, so bronchiolitis in kids will look very similar like this. And older patients with pulmonary fibrosis will have patches like this too. So do take that into account when you're examining. So you'll have to have quite a high suspicion for COVID-19 to take these findings as COVID. So as it progresses, those B lines become a bit more prominent, more frequent, but there will be spared areas between the patches. And then they'll develop these more prominent interruptions where the pleural line goes from being continuous to having this sort of thickened appearance and then almost like a chunk taken out of it. And then as they progress, they start to get these areas of consolidation visible up against the pleural line. So I call them subpleural consolidations. Really what they are is peripheral consolidation, because anything that's deeper in the lung with an air pocket outside between it and the pleura will not be seen by ultrasound. But viral pneumonitis, viral pneumonias like COVID-19 tend to be quite peripheral, so it lends itself quite well to ultrasound. But here in the middle in particular, you can see these fluffy cloud-like appearances of consolidation. There's much more thick looking pleural line. And we've got a bit of hepatization on that right one as well. So this view here, we've gone into in a transverse plane in between a rib space. So other findings, so Gio Volpicelli released this paper last year about some of the findings he felt was more specific for COVID-19, and he felt like this on-off phenomenon or light beam phenomenon, where in the acute phase of the illness as it's taking hold, it has these B lines that appear and disappear, like switching on off a light switch coming from a little band of pleura. And this just gives quite a nice demonstration of how it compares to CT. So here we've got an ultrasound done of the CT, and we can see how it corresponds to those little areas of ground glass opacification. Again, not specific either in CT or in ultrasound. It's just telling us that you've got this ground glass opacification. That can be other viral pneumonias as well, like H1N1 or influenza, but given whatever your pretest probability or your clinical picture is, you may think one thing's more likely than the other. And this is worth a look. Back when this all started, sort of March 2020, there was a chap in Spain who was a physician, and he developed COVID-19 and had a butterfly and scanned himself every day and just posted it up on Twitter, which was quite useful. So he started getting the odd B line around day 3. And then day 5, he had these really prominent ones, and then it got pretty much confluent day 10, and that's when he was at its worst. And then they continued on for months afterwards. So I'm certainly finding that pretty much everyone seems to have B lines now. So I think that the usefulness as a triage tool is diminished a little bit now that half the population's had COVID over the last year. So that leads me on to thinking about how it's useful. So in itself, I'd say that it's not diagnostic. I think you have to take it in context, and obviously your gold standard would be really PCR plus CT, because as we know, a PCR is only 70% sensitive. So when you're doing it, have a pretest probability in mind. If you've got an elderly patient with no infective symptoms, your B line patches are more likely to be due to fibrotic or a bit of pulmonary edema. So when you do report your findings, report your distribution of findings and report what the alternatives or the caveats might be to your report. So don't say this, this cannot exclude COVID-19, and this also might be appearance of any viral pneumonitis, something like that. We felt like it had a role in triage right at the beginning of the pandemic, where we didn't have any point of care testing, and we were scanning people in the ambulance, and based on their pretest probability and what profile they had, they were cohorted to hot or cold areas. And we found that did have quite a good sensitivity during the peak of COVID, and the specificity just started to drop as the cases dropped, as you would imagine. And I think it would be less useful now that we have alternatives available and the right cubicles for isolation. And it's also used for ventilation strategies, so knowing when to prone and knowing where your areas of ventilation mismatch are. So it can be used in ITU for that. And this study on the right was a Dutch study that looked at the sensitivity in their COVID patients, about 100 patients, and they found that their sensitivity was and specificity were 90 and 70% respectively. So not bad, but again, it'd be interesting to know how that varies with an endemic COVID-19 virus. So at that point, I will invite any questions. I saw a bit of chat. I hope I didn't speak too fast. But yeah, do shout if you have any questions. I'm happy for voices as well. So let's have a look. Any particular themes, Angus?
There's questions on whether the difference in zones and predictive values, anterior versus lateral versus posterior and so on, and what your experience was.
Well, right at the beginning, the Chinese published a few papers that we based a lot of our case on, and I mean the findings were much more prominent in the lower lateral zones, the posterior zones, so much so that it was almost not worth, but that's also in general where most people have their OB line. So we started to consider positive findings as a specificity started to drop. We started to consider positive findings as the ones that had B lines in areas where they wouldn't be more typical, so anterior and higher up posterior ones, and omitted the basal ones because they were just so common, and that did help our specificity a little. But in general, COVID does seems to have posterior basal as their highest or most affected area. I don't have any figures off the top of my head for that now. I did last year.
Yeah, and when you're scanning normally, Anna, do you use vertical mostly, or do you use horizontal, and other times when you use one over the other, that sort of thing?
So I pretty much always use vertical, the longitudinal, except for when I find a bit that I really want to define a bit more. So occasionally you'll get like this, you see with the light beam sign, you had a little stretch of pleura, and a bit of that might be stuck underneath the rib shadow. So if you orientate your probe transverse at that point, you might be able to get a nice stretch and see how thick that band of B lines is. And same with consolidations, often you can only see a corner of it, and so you need to define it a little bit more. But that lawn mowing technique, doing that transversely, I certainly did do it, but it became very tedious and it is quite time consuming and sort of negates the fact that it's a quick point of care test. So like I said, it wasn't quite enough payoff, but worth doing for learning the technique as well.
Yeah. And Tim Harris has asked an interesting question. Any thoughts on physiological versus pathological B lines in his population, saying the rule of 3 just doesn't seem to apply as many have old scars? When I worked in South Africa, it was probably pretty similar, actually. Be a lot of people with B lines in random places who were otherwise quite well. Yeah,
I completely agree. I've put it in there because, you know, that's what's in the textbooks, but I put it all in context. So I'd say, well, we scanned everyone who was coming through the door right at the beginning of the pandemic. So we got a good idea, and, you know, we were following up who had positive tests. Vast majority of people had some B lines, and lots of them have basal B lines, which are more than 3 and weren't pathological at all. And that includes young people. Either, you know, they've recovered from COVID or had something else going on. But yes, I don't think it in itself is helpful at all. And in the older population, we know that above the age of 60, people have many more B lines than the younger population without evidence of congestive cardiac failure on their CT scan. So the older they are, the more you have to take it with a pinch of salt. And it just goes like with any point of care scanning, you put it together with your clinical picture. And as we'll talk about later, if you can put it together with your echo or your peripheral DVT scanning, you can get a much better picture together. So it comes as a sort of comprehensive point of care scanning assessment.
Yeah, perfect.
Feel free to chip in, anyone. This doesn't all have to be me. Trower, what are your experiences?
Sure. Well, since you asked, yeah, just to comment on lung ultrasound in COVID specifically, because I'm just in the process of doing a systematic review on that topic at the moment. Yeah, there's a brilliant paper by Volpicelli that I've just posted in the chat. But basically, the evidence suggests it's quite a sensitive test for COVID, more sensitive than chest X-ray. But if you're really sick, like if you're hypoxic, have an oxygen requirement, then it's very sensitive. So if you have someone who's got an oxygen requirement, and has a normal lung ultrasound, then you should look for alternative diagnoses because it's very unlikely to be COVID. But yeah, interestingly, in the Volpicelli paper, they also looked at specificity in 2 different groups. So they looked at if you have all the classic signs of COVID, like bilateral, patchy B lines, confluent B lines, subpleural consolidations, pleural irregularity, like the full classic picture, then that was actually relatively specific, about 90% specific. Whereas if you just have like any changes, like just some B lines or whatever, maybe just on one side, then that's less specific. So I think specificity is actually a bit more of a spectrum. So rather than just having a point estimate of sensitivity and specificity for lung ultrasound, I think we could probably think of it more in terms of a spectrum. Like if you have the full classic picture, especially in a young, relatively healthy patient who shouldn't have any other lung ultrasound changes from any other comorbidities, then that could be relatively specific.
Thanks, Mike. Any other gems? The main hiccup we had at the beginning with, because we trained up our novices to do point of care lung ultrasound at the beginning with a sort of training program, and the main problem was mistaking congestive cardiac failure or pulmonary edema for COVID-19 in that older population. And I suppose I find it much more easy to tell the difference between the two now, having done hundreds of it over the year. But pleural effusions are obviously helpful, but aren't always there in pulmonary edema, and annoyingly are sometimes there in COVID, even though they said they were rare. But the pleural abnormalities were much more prominent in COVID, and although there might be the odd patch of some fibrotic changes in an older person's lung, the COVID changes were, once you got the good going B lines, you usually had some pleural thickening and roughening that made it a bit more obvious. But that was the main area where we had some diagnostic uncertainty. Okay.
Cool. Thanks so much, Anna. That's great. Guys, before I start, I'm going to go through some cases, just a few cases of echo with a couple of lung elements as well. But I wondered if we quickly go through and introduce people, as we normally do that at the beginning, and I probably forgot. So there's a few people here who I haven't met before. Also, we've got C3PO, who's actually Michael. So we've said hello already. As the great Professor Tim Harris is here. So Tim, do you want to introduce yourself and just tell us a bit about where you work and so on? No, he's muted. You're muted, Tim.
Yeah, it helps to switch the microphone on, doesn't it? Sorry. It's great to see so many familiar faces, and thank you for letting me join you. I trained in intensive care and emergency in Australia and came to London for a lot of years, actually. Got a ridiculous tax bill and came to the Gulf. As many, it's actually, I think, half of East London working with me at the moment from much the same thing, which is very good. I will be rejoining you in the near future if all goes well. And it's really good to see how you guys have picked up the mantle and made PocUS such a popular and well-led subject in London. I'm touched. It's making me want to come back more and more.
Good stuff. Brilliant. Thanks for joining. Who else we got? People pop in and say hi. Essang.
Hi, I'm an ST6 at King's at the moment. I'm just finishing a PG cert. I worked with Michael last year at St. Thomas's and a few other people like Mehrad as well. And Anna, I think I worked with you as well before. Yeah.
Yeah, and you've definitely and
yourself
gave me some little pushes in the past and some tips and advice. Thanks, man. Eve Omar's here. Okay, Lisa Summers, do you want to say hi?
Hello.
That's a great pick.
I'm an A&E consultant at Newham Hospital, part of Barts Health. Had the pleasure of working with Tim Harris many years ago.
Fantastic, thanks, Eve. Merad is here.
Hello, I'm Mehrad. I'm the A&E consultant at St. George's. I'm the ultrasound lead for the department, unfortunately. I'm quite chilling now in bed. Apologies for that.
All right.
And actually, the first place that I did emergency medicine in this country was with Lisa Summers in Newham. I don't know whether she remembers ages ago or not.
I think I taught you everything you know, didn't I?
Exactly, absolutely. Absolutely, you did.
And thanks, Merad. Merad did a great talk with Michael on regional blocks, which is available on YouTube. So have a look at the Slack group for that. Nishith is here. Just say hi, Nishith.
Hi, everyone. I'm SAS doctor in Lewisham Hospital, working with Anna, and I work with Professor Tim Harris as well in Whipps Cross Hospital. Hello, Professor Tim Harris.
Very good to see you.
Nice to see you, Professor.
Thanks, Nishith. Yuki. Hi, Yuki. How you doing?
Yeah, great. Thanks. Trying to brush up on my ultrasound skills. So Merad's got lots to lots to deal with, unfortunately.
Brilliant. And Matt Spriggs. Hi, nice to meet you, Matt. Okay. And there's a Peter. Nice to meet you, Peter. No,
Probably watching the football.
I suspect everyone's watching the football. Cool. Shall I crack on? So guys, I'm going to see if I can share appropriately. Let me see what I can do. Share screen. Okay. So can everyone see this all right?
Yep.
You see, fantastic. Okay, guys. So I'm just going to talk through some cases. I'm not going to try and teach too much on techniques, but I'll talk through a couple of things as we go. I'm obviously biased because I love ultrasound. I think it's great, but I think it's just a good, it's a tool. It's not the be all and end all. And I think it's important that we as enthusiasts sort of integrate it into our practice like that, because otherwise you don't want to become an us and them, which I think some people who aren't quite so au fait with ultrasound sometimes feel. But I think the combination of echo and lung ultrasound is phenomenal, and it should be bread and butter for the EM guys, because most people who are critically unwell have a problem with one or either or both. And so it can give us things that we can assimilate very quickly to give us diagnoses, or at least point us in the right direction of management. And of course, you've got to wonder when we're taking on a new ultrasound modality, what does this offer us, and how do we incorporate it into practice? And so when I speak to my friends who are respiratory registrars and so on, they're not very interested in lung ultrasound apart from Pleural, because they just CT everybody, because most of their patients are already up on the ward, they've been stabilized and so on, so they can get a CT and that's fine. But for us, lung gives us the ability to do it very quickly at the bedside and to track changes over time, and it's much better than chest x-ray. So let's go through, just shout out questions as we go, or we can talk about some stuff at the end, and I'll try not to be too long. So case number one. So case number one is a 54-year-old man with a background of diabetes and hypertension. He went to bed completely well, and then he wakes up at 3 in the morning, extremely short of breath. Doesn't have any chest pain, doesn't have any fever, doesn't have any cough. He's otherwise been fine. He's a little bit hypoxic and he's quite tachypnic, but he's got a good blood pressure and heart rate and so on. So what are we thinking? What are the issues? What's your differential diagnosis? What are we going to do next? Now, we obviously know there's a lot of things that needs to happen. He needs a line, needs bloods, needs an ECG, probably going to have a chest x-ray, but he's just rolled in with LAS, and what we can do straight away is put the probe on his chest. This is what we see. So from what Anna was talking about before, we can see here, this is curvilinear probe. Is some views bilaterally, we can see there's lots and lots of B lines. And there's B lines from the bases, and this is up in the anterior fields as well. So there's loads of B lines. We're going to then have a quick look at his heart. So this is his parasternal long axis view. Okay, so to remind us a bit of the anatomy, we've got the left atrium, the mitral valve, the left ventricle, and the aortic valve there. And you can see, you want to have a look, the PLAX view, the parasternal long axis is particularly good for looking at the left ventricular contractility and how well, what's the eyeball of the ejection fraction. And I like to think of it like this. So if your left ventricle is a room with two doors, there's an entry door, which is the mitral valve, and an exit, which is the aortic valve. If the room is emptied of people, and then you can open the door, which is the mitral valve. The door can swing right into the room easily. But if hardly any people leave the door, the room, then it can hardly open at all. And that's what happens. If you can see, I don't know if you'll see my mouse, but up at the mitral valve, when it comes up, it should come up nicely to slap the interventricular septum, which is at the top closer to your probe. And this is something we can measure using what we call EPSS, which is the E-point septal separation. I'm not going to go into it in much detail here, but essentially anything over 7 millimeters is considered abnormal and is predictive of a poor ejection fraction. So this is significantly increased. So we think, the ejection fraction is a little bit down there. And have a look, this is the parasternal short axis view. And what can we see here? We can see the mitral valve opening, that's the fish mouth view, down in the middle. And then just look at the what should be the donut shape of the left ventricle next to the croissant shape, top left, of the right ventricle. And can you see everything contracting in nicely, and what do we think? Is there anything unusual to have a look at? And what I would say is, here's the papillary muscle level. So this is a little bit closer to the apex. You can see the little crab claws of the papillary muscles there, and the same areas. Now, is the left ventricular wall contracting nicely? How's it all contracting together? And if you look with the eye of faith, you can say this bit looks probably pretty good, but actually up where the interventricular septum is and anteriorly, that's sort of flapping around. If we go back, you can see it very nicely on this view. If it plays, yeah, that top left part, the sort of 9 o'clock to 12 o'clock area, is not contracting very well. So that's what we call a regional wall motion abnormality. There's various maps that you can use that will explain which parts are supplied by which coronary arteries. And this area, which is the septal and anterior, so the anteroseptal area, this is supplied predominantly by the left anterior descending artery. So we can then say from that, okay, this gentleman has come in. You can see it again here, sorry. This is the apical 4-chamber view. So again, we're seeing all 4 chambers here quite nicely, and the valves. You can see that the septum and the apex, the little apex just at the top, is not contracting very well at all. It's sort of flapping around. And yet the right ventricle looks fine. It's not enlarged compared to the left, so the right side looks fine. The tricuspid annulus is bouncing up and down nicely, but that septum and apex of the LV do not look very happy. Now, if you rotate your probe counterclockwise, you get something called the apical 3-chamber view. This is very much, imagine a parasternal long axis view, but viewed from the apex. Okay, so it's the aortic valve is down bottom right here, and the mitral valve is here. And again, we can see that this wall here is contracting quite nicely, but the septum, which is on the right, top right of the screen, is again sort of flapping around, not particularly well. So this view can be quite good for evaluating where the regional wall motion abnormalities may be. And also we put a bit of color here, and you can see a jet sort of going back into the left atrium there. That's some mitral regurgitation. So this gentleman has a little bit of MR as well. Now, so in summary, we can say that from the lung ultrasound, He's got interstitial syndrome. There's loads of B lines. And we can see from the echo that he's got some significantly impaired LV function and some LAD territory, regional wall motion abnormalities. The RV looks fine and has normal longitudinal function, and he had no effusions. So by the time the nurses have got a set of obs and someone has wheeled in the ECG machine, we actually have a diagnosis, or at least a lot of evidence pointing in one direction. Now, he didn't have any ST elevation on his ECG, so he was treated as a non-STEMI, if you want to call it that. And he was discussed with the local PCI centre, who didn't feel he required transfer for acute PCI. So he was then admitted under our local cardiology team for acute MI medical management. Now, I'm not going to go into it in too much detail, but there is a school of thought that's saying that actually this isn't necessarily how we should be evaluating who needs PCI and who doesn't. And actually, there's some good evidence to suggest that now that we're so good with primary PCI in patients with STEMI, that actually mortality, all-cause mortality is higher in patients with non-ST elevated myocardial infarctions now than ST elevated myocardial infarctions, which is interesting. And there's a good post on this on MFRIC, which talks about the occlusion MI versus non-occlusion MI, and actually should we be looking for signs that there's complete occlusion, such as regional wall motion abnormalities and so on. But we know that PocUS in the ED in undifferentiated dyspnea, so this gentleman just had breathlessness, didn't have anything else, gives a very good concordance with your final hospital diagnosis, which is great, and is much faster. And this is the real benefit that PocUS and especially lung ultrasound gives us in the ED, is the speed with which we can quickly identify these patients and move our management in the correct direction. Studies have shown that with short training, we can accurately rule in patients with regional wall motion abnormalities in patients with STEMIs and NSTEMIs. And it's nice for us to go beyond our HOCM level 1 ultrasound, which is for our echo is a good foundation, but essentially is looking at whether the heart's beating and the really big stuff like tamponade. But if we can get into learning a bit more, maybe spend some time with your echo techs and learn a bit about assessing these things in a bit more detail, then we can learn quite a bit. And as I said, there's some evidence. There's a good paper there about NSTEMI versus STEMI mortality. So we'll go on to case 2. So case 2 is a 76-year-old with severe shortness of breath. She's a dialysis patient and she was dialyzed 24 hours previously. And she comes in absolute extremis. She's extremely hypoxic. She's working really hard. She's alert, but quite agitated. She's cold peripherally. She's got crackles throughout her lung fields. She's hypertensive, and she's no peripheral edema. So what we do quickly through the probe on her chest, and here we go. So again, interstitial syndrome, if you like. So there's more than 3 B lines per lung field. So you can see the ribs at the side there. You can see the pleura sliding nicely at the top, and you can see the B lines coming down. So this is bilaterally, and this is upper anterior chest. So you can see that, I mean, we scanned, there wasn't much point in doing the whole comprehensive scan. This patient's in extremis, so I just quickly put that on anterior, top of the chest, and we can see this. So I know that this is likely contributing to her breathlessness. So then we quickly have a look, and I'm only giving you one echo view here. I confess I didn't record them all. We just made some decisions quite quickly, but this contractility looks okay, and there's no obvious regional wall motion abnormalities, and the rest of her echo looked fine. So this lady has an interstitial syndrome with a relatively normal looking echo.
Ali, my feet are hurting. I know.
If we can mute Ali, thanks. Okay, and then we look at her IVC, and her IVC is pretty much flat as a pancake. Kian McDermott did a really good chat on IVC, which I'd highly encourage everyone to read, to listen to. It's on YouTube. and I have a bit of a bugbear about the IVC, and I'm not going to go into it in too much detail, but I think the IVC would probably read too much into our fluid responsiveness. And I think we're a bit behind the evidence on this. The IVC is a surrogate for CVP, which makes it a surrogate for right atrial pressure. And we've got to be a bit wary of it, interpreting it with much more than that. But this IVC is completely flat. For someone that we think has probably pulmonary edema, we can wonder, why is it that we think that, are they fluid overloaded, which would be your concern in a dialysis patient, but we can say that her right-sided preload is really probably quite low. So putting all of that together, we've got B lines everywhere, so significant interstitial syndrome with a pretty normal echo and a pretty flat IVC, which would not be necessarily suggestive of fluid overload. And she's cold peripherally, she's got no peripheral edema and so on. So this we treated as a severe crashing acute pulmonary edema, American spelling, sorry. So this is, we thought, pulmonary edema secondary to her severe hypertension. So we started on high dose GTN and we started on CPAP, and very quickly she'd settled. Within 10 minutes or so she'd settled, and we started to wean both of those. She was then admitted under the renal team, and I think they dialyzed her, as much as I said that I didn't feel that necessarily she was fluid overloaded, but I think they went on to dialyze her. And there's a good post on SCAPE if you want to have a look at that, or hypertensive pulmonary edema on MCRIT, so by all means have a look at that. So case number 3. Case number 3 is a 43-year-old man who comes in with left-sided chest pain, shortness of breath, palpitations and sweaty. He looks grey, he looks really unwell. He's got no known past medical history, and his TROP is raised. It's 180 with a point of care troponin we do. And so we're about to treat him for a non-ST elevated myocardial infarction, give him morphine, give him GTN. And of course, his ECG doesn't show any ST elevation either. So we think, great, NSTEMI, let's treat him. But someone has the bright idea of doing an echo. So we quickly do. And this was Banaz, the ultrasound lead at the Royal London. So have a quick look at that echo and see if you can see the obvious abnormalities and anything slightly less obvious. So I think what you can see here, if I can get the interventricular septum and the posterior left ventricular wall are really quite thick. So this is real significant left ventricular hypertrophy. And you can see here, with the eye of faith, there's a lot of noise because things are moving at high velocity. But at the bottom right of the screen, there is a tiny bit of posteriorly directed mitral regurgitation. So there's a little bit of mitral regurgitation there during systole. And you can see that the left ventricular outflow tract, everything's moving through at very high velocity, and that's why it becomes very bright. And we get this point where things are what we call aliasing, where it's too fast for the Doppler signal to make out, and so it makes it either bright white or bright orange or bright yellow, which you can see by the scale 67 minus 67 at the top left of the screen. So pop a quick M mode cursor down, as you would for your EPSS, you see something quite interesting. This you don't see very often. I'm confess quite intimidated by doing this with Anna also on the thing, because her echo knowledge is much better than mine, but we'll plod on and she can chip in, please, by all means, if I say anything wrong. But here we are you can see the E wave and the A wave. This is your mitral valve. So I've labeled on the left interventricular septum, which is the middle part here, and then the anterior mitral valve leaflet, which is the line that you can see at the top there, with just below E and A. The E is your early ventricular filling, which is, as you know, is passive ventricular filling, so the ventricle opens and is filled passively. Then you have the A, which is the atrial kick, as the atria contracts. And passive filling is around 60 to 80% of your of your ventricular filling, and then your atria contributes around 10 to 40% depending on your heart rate. So that's your diastole time, which I've highlighted in green, and then your systole time, which is in yellow here. Now, if we compare this with a normal M mode, which you can see on the left, you can see diastole time, the E and the A humps there, and then during the orange part where it's systole, you can see that the mitral valve leaflets are opposed, as they should be, they're closed. So on the right, again, looking at this one, this is what we call SAM, or systolic anterior motion of the mitral valve. Okay, so during systole, the anterior mitral valve leaflet has moved anteriorly close up to the interventricular septum. So the mitral valve is not closed, hence you get some posterior mitral regurgitation, which we saw before. And you also get what's called dynamic left ventricular outflow tract obstruction, which is where the outflow tract itself is closed off as that mitral valve leaflet is sucked into the outflow tract, causing some obstruction. And this, of course, contributes to your poor cardiac output, gives you the chest pain and all the other symptoms that you would expect. So this is what happens in HOCM. Here I'm going to derail a bit. Please bear with me. A bit of physics. So the Bernoulli principle. The Bernoulli principle tells you what happens when a tube changes size. So to maintain flow through a tube, a narrowing of the tube will cause an increase in velocity and a corresponding drop in pressure to ensure that everything goes through. So if you imagine you had 3 lanes of traffic at 60 miles an hour, you would need 1 lane of traffic at 180 miles an hour to maintain proper flow, and this is why you get traffic jams. But the drop in pressure is the important part. This potential energy is converted into kinetic energy, and this is why you get the drop in pressure, because it's the potential energy that gives you the pressure. So that little diagram explains that a little bit. So that's the Bernoulli principle. So through that narrowing of the left ventricular outflow tract, we're going to have a really high velocity. That high velocity then contributes to what we call the Venturi effect. The Venturi effect is that if there is a pressure in a fluid, which would be a gas or a liquid, which is lower than the surrounding, then other fluid will be entrained or sucked into this flow. So remember, we said that the velocity is really high and the pressure is really low. So with that low pressure, the other things will be sucked in towards that area, and this includes the anterior mitral valve leaflet. So the anterior mitral valve leaflet is sucked up because of the high velocity and the low pressure across the left ventricular outflow tract, which causes the systolic anterior motion, and that causes obstruction of the outflow tract itself. So what we have to think is, this also explains how Venturi masks work, because you know the flow, and that therefore you know the velocity, and that entrains a certain amount of air, which gives you relatively precise concentrations of oxygen, which is why they're useful in COPD patients and so on. So knowing that physics allows us to work out how to manage a patient who is having dynamic outflow tract obstruction. What you want is a good preload. You want slow and steady rather than fast, because if you have a really fast, empty, hyperdynamic heart, you're going to have that high velocity, hence low pressure, hence more dynamic outflow tract obstruction. So you want to give IV fluids. You want to avoid hypovolemia, avoid venodilators and diuretics. You want to support the afterload. You actually want a good afterload, because you want to slow that, you want to reduce that pressure gradient, therefore reducing the velocity and therefore reducing systolic anterior motion. So that means alpha agonists like phenylephrine, metreminol, so on, and avoiding vasodilators such as propofol, which is why the anaesthetists are always not very keen to intubate someone with aortic stenosis, because if you give them propofol, they're going to really struggle. So this patient, we said he had notable left ventricular hypertrophy. He has systolic anterior motion and some MR with outflow tract obstruction. So we didn't give him the GTN, which would not have been a good move. He gave him a little bit of fluids and analgesia, referred him to cardiology, who then started him on beta blockers and diagnosed him with HOCM, and he's under their follow-up now. So case 4 is not quite so crazy. Well, all right, everyone breathe a sigh of relief, and this is the last one. So case number 4. 65-year-old female with sudden onset chest pain and shortness of breath. And she comes in, she's cyanotic, she looks like death. She's got hypoxic, even on 15 litres. She's got a low blood pressure. She's shocked. She's blue. She's cold. She's got ST elevation in AVR V1 and V2. The med reg on in this DGH happened to be a cardio reg, so he did a quick echo, which was quite difficult. But he had seen the ECG and he thought, okay, let's have a quick look. And he says, yep, there's a regional wall motion abnormality. This is a STEMI. Okay. So we discussed with the local cardio center who felt she was too unstable for transfer, which is classic DGH conundrum. So we had a quick look and we did a bit of lung ultrasound. And so this is what you can see here. This is with the cardiac probe. And you can see that there is the rib shadows. You can see some pleural sliding. On the right, you can see one B line occasionally, but as we said, that's not unusual, and that could be physiological. So for a woman who is so profoundly hypoxic, as Michael said, if your lung ultrasound is relatively normal, you have to think of something else. So we were questioning, why is it that this woman is quite so hypoxic? And people saying, oh, she's having a STEMI, she's consuming lots of oxygen. I said, no, that's not quite how it works. So what do we do next? So we have another quick look whilst they're talking to the cardio center, and we try and have a look. And this isn't her echo, unfortunately I didn't record it, but I wonder if anyone can see anything on here that they think is unusual. Rather than a regional wall motion abnormality, and it was a difficult echo, but we could see, I wonder if you think that this LV looks a little bit D-shaped. So we thought so. We then thought, okay, she's in cardiogenic shock. She's got normal pleural sliding and no B lines, so she doesn't have an interstitial syndrome. So why is she so hypoxic? And she's got a flattening of her interventricular septum into the LV during systole. This is suggestive of RV pressure overload. And whilst we couldn't see very well, she did have a dilated RV and so on. And she was rushed to CTPA. She had a massive saddle embolus. And so she was transferred with critical care to have a catheter-directed thrombolysis as part of a trial at the local tertiary centre. So thank you all very much for listening. Any questions, please fire away. Here's some references and a little bit of if you're interested, it's totally up to you. I post weekly cases from the Royal London on this, which is their unofficial website, which was called Under the Helipad, and there are weekly cases of all sorts of PocUS things submitted by different people in the department, and we post those on there. So if anyone's interested, you can have a look and a browse, but there's plenty of these around on the phone community. Cool, thank you very much.